Alright guys, before we get into talking about pulseless electrical activity, we're going to talk about how to troubleshoot during a code and the things that can cause our hearts not to beat when we're expecting them to beat, or they quote-unquote should be beating. And of course we're talking about the great H's and T's here. And so let's real quick start the slideshow because I'm forgotten to do it. Alright, so I kind of wanted to draw on the slides on this one. That's why I engaged it like I did. This actually comes from the ACLS book, with the exception of if I can hit the pen, it would work better. Okay. Except for this guy right here, but we're going to kind of talk about him real quick. When we're talking about the H's and T's, we're talking about reversible causes, okay? And I can't stress that enough. Reversible causes, okay? Things that we can fix to make everything work better, okay? And we've kind of touched on this in our physiology and our pathophysiology. If we don't have enough volume circulating through our blood, through our pipes, everything's not going to work. If I don't have enough oxygen attaching to the red blood cells that are getting moved by this system of pipes, it's not going to work. If I got too much acid in my blood because I'm creating acid because the oxygen's not moving, well, I restored that, but at this point I've got there's too much acidity in the bloodstream, there's too much of that lactic acid, there's ways to fix it. And so I kind of want to go over these and make sure that you guys understand it. I would say that you need to memorize all of them. Definitely all of them. By the way, this one right here, they actually took this one out, and they actually took this out of the ACLS algorithm. However, again, the hypoglycemia I think still needs to be in there, and I'll explain in a second. So hypovolemia, again, there's not enough circulating blood volume. Again, the true fix to this, by the way, is blood, okay, or blood products, okay. But that's the problem. Do we have any blood? Usually no. Matter of fact, what we use is normal saline or lactated ringers, a crystalloid solution. It is, when I say a temporary fix, it's putting a Band-Aid on a burst pipe, okay? It's just not, it helps keep the pressure up. Now understand that there's other hypovolemic states. You can have a patient who is septic and has been volume depleted. So in that case, lactated ringers, normal saline might work very well, versus if they're bleeding out, and then if we haven't fixed the bleed and we're trying to pump them full of normal saline, well, we're actually doing probably a disservice. So again, hypovolemia, again, too little volume in the pipes. Hypoxia, again, O2 saturation. So is this something that we can do? By the way, in hypovolemia, can we do something about this in EMS? I would say, yeah, we can. Again, but understand that we're putting a Band-Aid on it. We really need to get them blood product. Hypoxia, can I fix that? That would actually we're pretty good at. Put a tube in their throat, put a advanced airway in, monitor their end-tidal CO2, check for their gas exchanges. And then make sure that their O2 saturations is greater than 94%. Yeah, that fixes our hypoxia issue, okay? Now understand, though, that there are two types of hypoxias. There's the actually getting it to the lungs hypoxia, and then there's the actual cellular hypoxia. So let's say an overdose situation, it would probably be a cellular hypoxia, and which these are the patients, of course, that we oxygenate. They've got a 99 sat, and they're not getting better. So keep that in the back of your mind as you're working on these patients. But the thing that you can do something about, though, is again making sure the air is going in and out. All right, hydrogen ion acidosis. Ooh, now we get it. Remember all that stuff that I was teaching you guys first semester about acid base balance, and I talked about it with how do we make sure that we do the acid-base balance? And we're going to dive into it a little bit deeper, actually, as we finish up cardiology here. But can we fix this in EMS? And that one is, yeah, we can, or at least we can start to. Okay, what we really need is a blood gas in order to determine that. But if we're doing good ventilations on the patient, that's going to fix our respiratory acidosis, okay? If we do have sodium bicarb, if we think that it is a metabolic acidosis, diabetic ketoacidosis patient that is so bad that they've actually arrested, that would be a good example of when, yeah, we could give sodium bicarbonate and it can actually make your patient better, okay? Again, the definitive treatment is a blood gas, by the way. We really need a blood gas for this to make sure that we're treating it correctly, and that's what we're going to go over in a little bit. But again, if you've got a patient with an extended downtime, it's probably a good bet that they have an acidotic state. And again, good ventilations is probably the number one thing that we can do to help that. Good CPR, and then make sure that we're doing, again, if we think that it's a metabolic cause, we can administer sodium bicarb. Hypo or hypokalemia. And by the way, not only kalemia, I think sodium fits in there. I think calcium fits in there. I think magnesium fits in there. So any of the ions, okay, any of the ions at this point, all right, if it's hyper or hypo. The common one that causes problems is, of course, the hypokalemia. And again, hyper or hypo, whether they've got the peak T waves or the flattened T waves with U waves for the hypo, or the hyper, again, is when you've got peak T waves and then the elongation of the QRS complex. And again, there's some things that we can do to help that. Again, we can administer calcium chloride. We can administer large amounts of albuterol to help hyperkalemia. For hypokalemia, they got to get there and get potassium put on board. But pretty much there's not much that we can do about this guy right here. I mean, there really isn't. In the EMS setting, again, you really need lab values in order to figure that one out. Now, hypoglycemia, we can definitely fix. Again, we take a blood sugar, and again, everybody gets in a hurry. Take the blood sugar on the patient. There ain't nothing better than coming in with a cardiac arrest. We can't get them to straighten out. You take their blood sugar, and it says low. Okay? And yes, they can. Low sugars can cause ventricular tachycardia, can cause them to arrest. So make sure that you check your blood sugar. Okay? It sounds dumb. Check your sugar. All right? Check your sugar. Hypothermia, really simple. They're not dead till they're warm and dead. Okay, if they're cold, you need to warm them up. If they're hot, by the way, this also goes for hyperthermia. By the way, everybody says it's just hypothermia. Well, you can actually Bane brace them as well. So if they're too hot, cool them down. If they're too cold, warm them up. Again, gently move these patients, because you can actually bump them and send them into VFib. And again, this is one that, again, I reiterate, they're not dead until they're warm and dead. We got to warm them up, okay? There's been people down for literally an hour or longer that have survived resuscitation with no real bad outcomes. All right, toxins. Now, everybody jumps the gun on this one, and they run over here and they say, yep, Narcan. Okay, well, guys, Narcan is a wonderful drug that works really good for opiate overdoses. It doesn't do anything else for any other toxin. So the real key to this one is got to find the agent that's causing the problem, and then administer an antidote. An antidote is the key here, okay? And again, different drugs have different if it's a tricyclic antidepressant overdose, sodium bicarb. If it's a beta blocker overdose, it's going to be glucagon, is one of the treatments that we're going to use. So you got to know what it is that they overdosed on, and it's a key thing. It's where you become kind of a detective. But again, until you fix that problem, they're not going to come out of an arrest state. Now, cardiac tamponade. Again, this is where the blood is filling up inside the pericardial sac between the pericardium and the myocardium. It causes essentially what it does is over here, we got our heart, we got our sac around it, and the blood starts to fill up into this area. And then what happens is it starts filling up even more, less squeeze, less squeeze. You're going to see narrowing pulse pressures with a degrading blood pressure that's going on. What I mean by narrow pulse pressure, they start out at 110/70, they go to 100/80, they go to 90/80, they go to 80/70, 70/60. Again, really, and then they will continue to degrade. The only way to fix this is stick a needle in there and drain this blood off. And again, we are not trained to do that, so therefore get them somewhere where they end. The other thing that you might hear maybe is a muffled heart zone. You're going to hear where there's a definite interference. Again, somebody that can drain the blood off is what you need. Now, tension pneumo, we can definitely stick without a doubt. Okay, guys, pneumocentesis, right? Pop the lung. We can definitely, matter of fact, if it's a traumatic arrest, guys, I can tell you right now, if it is a traumatic arrest and it's involving the chest wall or the abdominal cavity, most of the time I will stick a needle in there no matter what. Dart both sides of the chest, okay? And the reason that I do that is because if it is a tension pneumo, it's going to fix your cardiac arrest immediately, okay? Don't waste time. You start bagging the patient, but by the way, if you're bagging the patient and they have a pneumothorax, you're going to make them worse. So again, by the way, if they're in a traumatic arrest, they're not getting any deader, stick a needle in their chest, okay? The worst thing is you got about a 5% chance of giving them a pneumothorax. Oh, okay, well, believe me, if he's in an arrest, this is the least of his problems. All right, thrombus, whether it be coronary or pulmonary, okay? Coronary thrombosis, so we know more as a MI, by the way. And we usually call the pulmonary thrombosis a PE. Again, there's nothing we can really do for the PE. The heart attack, hopefully we might have seen it earlier when we had the patient. Again, get them to a cath lab or get them to a surgeon where they can extract. But usually if they arrest by that point, there's nothing that we can do. Let's see here, by the way. That's something we can do about. This one's depends. And then trauma. They've actually got us taking trauma out for the ACLS one. So is there anything that we can really do? Because usually trauma ends up being one of these guys up here. Hypovolemia, hypoxia, tension pneumothorax, or cardiac tamponade. So again, they've taken the trauma one out. So so make sure that you know these guys right here. Hypovolemia, hypoxia, hydrogen, the hypo ions, hypoglycemia, hypothermia, toxins, cardiac tamponade, tension pneumo, and coronary thrombosis, pulmonary thrombosis. Okay? Now again, when you're doing these and you're trying to figure these things out when you're doing your scenarios or calls, guys, focus on the things that you can focus on, and usually focus on the ones that we can quickly check, okay? And go off the index of suspicion of what, again, if you get there and the patient's a known asthmatic that was having trouble breathing and now has stopped, more than likely they've got a hypoxic situation that they're in respiratory acidosis so bad that they've arrested. Start putting these clues together as far as your H's and your T's to start better treating your patients. By the way, this doesn't also work. It works for PEA. We primarily, I would say, this is what we start thinking in PEA and asystole. Okay, but it's actually, I would say, all the cases actually. If you've got a VFib or a VTAC that is not coming out of it, again, you give them epi, you give them amiodarone, they're just not coming out of it. At this point, start thinking about these H's and T's. This is going to be our key thing. Start thinking about those, okay? Start going, hey, wait a minute, I need to fix these, okay? Especially if they're going in and out of it. Again, make sure that you can correct these things. These are the reversible causes and contributing causes, but reverse the ones we know that we can do. And again, these guys here, we've kind of trained since the first ones, okay? Hypovolemia, hypoxia, good ventilations. We've been training on that, making sure their sugar's high enough, I should say, making sure the temperature's where it's supposed to be. Okay, air's going in and out, blood's going around and around. It usually will help correct all of those situations that we've got EMS next to. All right, that's it for the H's and T's. Again, got to memorize them. Memorize, 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 memorize. And I will see you guys on the next one.